Welcome to our CME and SDMS CME accredited ultrasound webinar. How do you get those images? Optimization for echo. My name is Matt Wilson, representing the International Contrast Ultrasound Society, ICUS, in collaboration with Northwest Imaging Forms, the CME provider for this program. Northwest Imaging Forms is accredited as a CME provider by the ACCME. Northwest Imaging Forms designates the CME activity for one Category 1 credit towards the Physician's Recognition Award of the American Medical Association. Sonographer SDMS CME is also provided for those wishing to receive up to 1 hour of Category AE credit. The planner of this CME activity has nothing to disclose. All relevant financial relationships have been mitigated. Please find the Q&A button on your screen's lower menu bar to readily ask questions of the faculty as you are listening to the respective presentations. They will respond to questions in the discussionary period towards the end of our time allotted. It is now my pleasure to introduce our first speaker, Joan Olson, BS, ACS, RDCS, RVT, FASE, Manager of Echocardiography Lab, Nebraska Medical Center, Omaha, Nebraska. Joe.
Thank you, Matt. Nice to be here. And I'm glad all of you are here joining us for this webinar today. We are very excited. We have another faculty member, Jess Stout. She is the medical director or the technical director and manager at Beth Israel in Boston, Massachusetts. So we welcome her as well. So we're going to just get started here with some introductory slides before we get into the meat and gravy of this. So on behalf of the co-presidents of ICUS, Dr. Stephen Feinstein and Dr. Stephanie Wilson, we welcome you to this webinar today. ICUS is a global professional society solely focused on ultrasound enhancement agents. This is a great society, so if you haven't joined, you should do so. There's members in 60 different countries. There's physicians, sonographers, nurses, scientists, industry, and patients that are involved in this. And ICUS never charges any fees, so this is great. If you want to join, you can just hit this right here and you can go ahead and join ICUS. There's free webinars and CME credits. There's a free website, mobile app, ICUS Connect, and there's also free contrast news monitors as well if you're a member of ICUS. They have an Instagram case of the day. This builds confidence and confidence in your contrast enhancement scanning abilities. They have a free sonographer training resource hub, which is great for sonographers on the website. And like I mentioned, you can download the ICUS Connect, and this is your gateway to 24/7 ICUS. Anything that you need is right on that app. And they do have this news monitors, which monitors the global trends and developments. And this is bubble news and trends in over 60 countries. So this is really quite amazing what ICUS has done with their website and how they connect with just everybody across the country, across the globe. So this is really awesome. And you can explore the website if you want to just go on ICUS the website, and they have so much stuff on that you can just explore. You can get lost in it because it's amazing. They have a lot of stuff on there. So just take some time. They have the webinar calendar, registration, guidelines, protocols, training materials, how to set up your contrast lab, case of the day challenges, bubble TV interviews, and bubble blogs. They have sponsored virtual exhibits with product information. So a lot on the website. So if you have a few minutes, just go on the website and kind of explore. We want to encourage all your colleagues to join ICUS and become a member. Once again, it's free. So if you haven't already, please do so. So we also want to make sure that we appreciate our sponsors of ICUS. And then today's agenda, we're going to talk about, I'm going to start off the webinar today. I'm going to talk about scanning optimization and machine settings. And then I'm going to hand it over to Jess, and she's going to talk about administration techniques and troubleshooting some artifacts. And then we're going to bring it all together at the end, and we're going to have some case studies and maybe a few other images just to kind of bring everything together at the end. So I'm going to go ahead and get started. And then we're going to have questions and answers as well at the very end. We'll make sure we save some time for that. So I'm going to go ahead and get started. So my talk, I'm going to start talking first. I'm going to talk about scanning optimization. Then we're going to move into machine settings and kind of bring it all together with those first two. And then, like I said, we're going to hand it over to Jess, and she's going to talk about administration and troubleshooting. So high quality diagnostic images, I really believe at the nucleus of this is kind of what we're going over in our talk today. So we're going to talk about patient positioning, we're going to talk about some breathing techniques, and then we're going to move into the machine settings and optimization of those settings. And then Jess is going to talk about agent administration and different techniques and how to administer the contrast. And she's also going to talk about troubleshooting, which I think at the very end, that's what you do at the very end of any image is that you have to troubleshoot. So all four of these are just very, very important to the nucleus and making sure that we're getting that high quality contrast imaging that we're looking for. It's kind of a sequence of events. So you want to, start with your patient positioning, your 2D imaging optimization, and then we're going to move into the machine setting and the presets, and then the contrast administration, the techniques, and then the contrast image optimization and that troubleshooting. And hopefully at the very end of that, you're going to get this nice diagnostic image of contrast. So let's get started. These may seem pretty basic in the beginning, but I just can't emphasize enough how important this is in the beginning of your studies with contrast imaging, is to make sure that we have the correct patient position and the room prep and the prep for the patient as well. And breathing is the second most important thing, I believe, in getting your patient ready to get those high quality images. So room prep, patient prep, not every room looks like this as far as inpatient. You're going to have some inpatient rooms that are really difficult to get into. So it's very important that you have your setup when you go into those rooms and good to go before you start your imaging. In the outpatient setting, you're going to hopefully have that nice dropout bed that you can, get that patient up in that left lateral position to make sure that we can produce those good images. So if you do not have a dropout bed in your lab, please make sure that you advocate for that, because that's really, really important to have that. Inpatient's a little bit different. You kind of have to go in there and set up the patient and maybe get some help to get that patient up on the left-hand side. Because I would say 95% of patients, their images are better up on their left-hand side. So just make sure you get that help in the beginning, and then you're going to be able to get those nice non-foreshortened imaging fields if you set up your room and your equipment correctly in the beginning. And you're going to be able to see that true apex. Like I mentioned before, the ideal position is that left lateral decubitus position with the left arm raised above the head. This position approximates the heart towards the chest wall and spreads those ribs. Also, the ASE came up with some guidelines for comprehensive transthoracic echocardiographic examination. This is a really good guideline paper. If you haven't had a few minutes, please go in and read this guideline paper. It was really well written, and they have some really good key points to optimize your scanning techniques. We just want to make sure that we're always using everything that we have at our fingertips. And this could be, tilting, the sweeping, the rotating of the probe, the sliding of the probe, rocking, and the angle of the probe. All of these are so important when you're scanning. Just make sure you kind of use all those different abilities that you have at your fingertips to make sure that we're getting in between those ribs. We're taking that nice big breath in, and we're kind of using all those different, things that we can use to optimize our image. Patient positioning. UAA's imaging is best performed from the apical window. So the anterior position of the right ventricle can result in attenuation and shadowing when using parasternal views. So you want to make sure that you start your imagings with 4-chamber, 2-chamber, then 3-chamber, your long axis. Then you can also use the parasternal long and the parasternal short images if you want to with contrast imaging, because sometimes that does add a lot of value to your study. You can really visualize the RV a lot better sometimes in those two views. So I would say do all of them. I think they're all very, very important. But the sequence does allow for the assessment of all the 17 LV segments. Here's an example of an outpatient imaging, same patient, same day. So the image on the left here is not a bad image. But if you went one intercostal space down, you had that patient way up on the left-hand side in that position that we just talked about. This is the same patient, just one intercostal space down with a nice big breath in. You can really bring in that true apex. And here you can see that the right ventricle is not really wrapping around the LV as you can in this image. It's a little bit wrapping around there, so you can tell you're a little bit foreshortened. So I would say this is your best optimized image for this patient. This is a patient, 2D optimization, same patient. This is the inpatient setting. So this patient was done one day, and the next day I think we went back and had to take some more images. So I just want to kind of emphasize this image is not bad. Once again, I think if you did contrast, you probably get okay images with this, but this just takes it one step further where you got that septum right down the middle of your screen. And this way you're going to really be able to optimize the LV, and you hopefully maybe see some of the RV when you're scanning and when you're introducing that contrast agent to this patient. So just make sure you have that septum right down the middle of the screen as much as you can. And that may, like I said, take some breathing, take some moving of the patient more up on their side. And sometimes you roll them back just a little bit. It just depends. But it really is a dynamic process, and you want to make sure that you have that patient in that best position possible. This kind of takes it another step further here. So this is a patient, which we know we have really, really difficult patients to scan. We have LVADs, we have RVADs, we have heart transplants, we have just everything you can think of nowadays. So it's just important to try everything. So this patient, I remember I scanned this patient, I went up and this is the first image I got, try to get that patient up from the left-hand side. But this is the image that I got. So in this patient, sometimes when they have these LVADs and RVADs and stuff, their heart is repositioned. It's not in the same, obviously, same position. Sometimes things are moved around. So in this patient, this was actually a patient that was better scanned flat in the back, supine versus in that left lateral position. And it went way lateral, way underneath, found this beautiful window of this patient, which we rarely get, but it was amazing. So just to point out that sometimes it's not the normal, and sometimes you have to go out of your normal positions to get good images. And in this case, it was amazing. We could really see the LV really well on this patient for having an LVAD, RVAD. It was amazing images. So I think this really helped in diagnostically, getting these images, was making sure that the imaging plane was correct. So like I said, sometimes you have to move out of your norm. But like I said, probably for 95% of patients, it's that one position and making sure they're up on their side. This is same patient, same day, one day apart. Just another example of how important it is to kind of, if you can, to optimize all of the LV segments and increase the infusion rate if you need to opacify the entire LV. So this one, you can see that the images were a little bit off on this patient. I don't know if it was just because they didn't have the patient all the way up on the side. No, that's, like I said, there's all those little bit of movements that you can do that help to create these images. And this is a combination of, I would say, a combination of both not having the correct window, and then maybe the contrast just needs to be a little bit more injected a little bit faster for this patient. But you can, the more you try, and once you get that image, you kind of know when you're in that spot, when you're in that sweet spot, when you're scanning, this is what it is. You get that feeling, and it just overall it just gives you everything better. Obviously it's going to give you the entire LV and the 17 segments. And sometimes when you're off a little bit, like this image here, you can kind of tell you're off. So you need to might have to do some further adjustment. And like not every patient is the same by no means, and then not every patient has optimal windows. So that's but most of the time, I would say 95% of the time, you can get some good images, especially with contrast if you know you're going to use contrast. This is another patient, same day. Go this one pretty quickly here. But this is a really, really important case. So this patient came in with a PE, and they were kind of rule out source of emboli. He was in the unit, he was vented, he was really in rough shape. So they wanted to know if anything was going on in the LV, if you could see anything in the LV or the RV. So these are the images that was got the first day. This is a 2-chamber, this is 4-chamber 2D. And this is with contrast on both of those. Nothing was really, didn't look too out of the ordinary on this patient. I don't know if you see anything or if anything was missed on these patients. But as far as these images go with contrast, we couldn't really, nothing was seen on these images. This function may have been down just a tish, but otherwise there was no LV thrombus or anything visualized on this patient. So we were called back to do another echo on this patient the next day. And lo and behold, look what we found. So I believe in this patient, it was just, the patient was still in the vent. This was the next day. So they had done a CT. So they had found out that this patient supposedly had this LV thrombus, but we didn't see it on the previous study. So we were asked to go back to see if we could appreciate that thrombus on this patient. So we went back and scanned again, and just going like on this patient, same thing, vented, nothing's really changed with the patient. Just, maybe we went in the room and got the patient up on the side a little bit more, because sometimes even like a couple inches, a pillow, a wedge makes a huge difference. And then this patient, I remember too, was very thin. So it was hard to get in that rib space you need to get into. Sometimes that's difficult. So just by moving that patient up just a little bit and being able to get into that that space that you need to get into is really important. So you can bring that probe down one intercostal space, and then you can really visualize the apex. And lo and behold, there was a thrombus in the apex that they did see on CT. So just goes to show you that a little bit more effort to get that base image, get that 2D image is what really matters when you're scanning. And it can make your job a whole lot easier if you just get those images. And this is, we want non-foreshortened images, not just for for contrast mainly. And then sometimes you have to go back and you take your Doppler and your color. You may not need that nice non-foreshortened image all the time. But for contrast, we want to make sure that we always try and achieve that image before we administer the contrast. So just to kind of show you here, side by side. So this is the first day, the 4-chamber, and the second day, the 4-chamber. Just the difference of making sure that we can see that true apex, which really brings out that defect here in the apex. And sometimes with thrombuses, they can be anywhere. So this is just one, you need to cover all your bases. Sometimes you need to do foreshortened, non-foreshortened to make sure that you're not missing a thrombus. But in this case, the non-foreshortened images were not done, and we missed the thrombus on the first day. So just a very, very important take-home message there. Breathing is the next thing that is vitally important to proper imaging for contrast. This is a nice 4-chamber here. You want to make sure when you take that nice big breath in, you hold that breath a little bit if you can. Sometimes, obviously, that's not possible. But if you can, that's just so very important to contrast imaging, is holding that position, getting that true apex so you can see that. And so the physicians can appreciate when they read the studies, they can appreciate all the LV segments and the apex especially, but get a nice good 2-3 beats of that contrast image so you can kind of really have time to appreciate it. So that's where the breathing, if you can, comes in. It's really, really important. This is just an example of taking that nice big breath in. You can see previous to taking that big breath in, you couldn't visualize how the RV or the LV, but once you take that big breath in, boy, it just makes a huge difference. And it makes your imaging a lot faster too, especially when you're administering the contrast. If you got that good image, you save a lot of time by just making sure you do that breath in, hold, boom, do your imaging. As long as your machine's set up correctly and everything, and you got everything ready to go, it really saves a lot of time imaging too. Okay, so I'm going to talk a little about the new guidelines before we get into the machine settings. So manufacturers should provide users with information on the contrast-specific algorithms employed on their systems and how to readily access them. Imaging system presets for UEAs should be considered a starting point. Users should familiar them with changes in system settings that are likely to improve image quality and reduce artifacts for individual patients. Recommendations for imaging. Low MI imaging, including the use of nonlinear and multi-phase detection methods with or without brief high MI flash impulses, should be used to image UEAs during assessment of regional and global LV function. So now we're going to get into the machine settings. Every machine should have their own setting. Obviously, there's a lot of different vendors out there. And if you have one specific vendor that you have in your lab, we have one specific vendor. So we're really good at that setting. And we know how to optimize those images. We know how to get those images. We know how to set that machine up. And some machines may have several different platforms. So whatever you have, just make sure you have a setting that works for your machine. And whether you're using low MI imaging or whether you're using conventional LVO imaging for contrast, whatever you're doing, just make sure that you get with your vendor and make sure your settings are the same in all the machines and they're set up the same, because sometimes they can change. Ours, sometimes some just change. Like if we do an upgrade or if something's fixed in the machine, it's a constant battle. We have 20 machines. So you just have to make sure that they're always set up right, because sometimes you look at images and it's like, what the heck, what happened? Or why does this not look right? So just make sure that you always kind of look over your settings, make sure they make sense. And yeah, so we just have it automatically presets on our machines, and that's what every machine should have, is a preset for contrast. Just like you have a preset for adult echo 2D and everything, you should have your preset for contrast as well. And once you have that set up, we're going to talk about the settings you need for that machine. We're going to talk about the frequency here. We're going to talk about compression. What are you imaging at? What are you receiving? We're going to talk about your frequency, and we're going to talk about your MI, what your MI should be set at, and what your flash MI should be set at. And we're going to talk about focus as well, to make sure you have this nice uniform image with contrast. So your MI, your mechanical index, is your transmit power. If your MI is set too high, this will cause too much microbubble destruction. And this should be set between 0.2 and 0.3 MI with conventional LVO imaging. It should be set between 0.1 and 0.2 with myocardial real-time perfusion imaging. And your MI set too high can cause swirling of the contrast in the LV, which I think Jess is going to go over some of those artifacts seen with that. And once again, so if your MI is set too high, like greater than 0.5, this is where you really, you get that destruction of those microbubbles. And just to break this down a little bit further, what we're talking about here. So this is your conventional 2D imaging, and your MI with that is usually around 1.4, and that's for conventional 2D imaging. Take it one step further with your harmonic contrast imaging settings with your conventional LVO, you're sending and receiving at 2 different frequencies. And your MI then can be anywhere, it's around 0.35. Now, if you're going to use that very low MI imaging, which we're going to talk a little bit about today as well, where you can get these really nice contrast images of the whole LV here, and you can appreciate that LV thrombus as well. But here, you're sending and receiving at the same frequency. So that's the main difference too with that, with your settings. This is sending and receiving at different frequencies, and this is sending and receiving at the same frequency. And usually your MI is set to around 0.18 or a little bit higher, but not usually over 0.2. And your frame rate goes down too as you use contrast. So just some advantages of using that very low MI imaging compared to your conventional contrast imaging is that you can really appreciate the basal segments here in this image. It really brings out this a little bit better, and actually it brings out the whole LV cavity a little bit better, get really good opacification of the entire LV. So MI, if you have your MI set too high, you're going to destroy those microbubbles. So this is a case where your MI is set at 0.28 and you're sending and receiving at the same frequency. So in this case, you want your MI to be probably below 2. So as you can see here, you're really destroying those microbubbles in the LV. And here, we're not destroying near as many bubbles, and your MI is set a little bit less. It's set around 0.18. So here you can see we get a much better delineation of the LV cavity here and not destroying those microbubbles. Your dynamic range, your compression, is the range of ultrasound signals processed. It's the ratio of the highest to lowest signal, and it's the concentration of microbubbles following the immediate injection. And here, here's your compression, and usually we set it around 50, but that could depend on your machine. So like I said, this is our machine, but ours is usually set around 50. And our persistence, but I don't have that in my thing here, but persistence is usually either turned off or is low on when you're doing the low MI imaging. Your focus is the narrowest area of the beam with the greatest ultrasound intensity. So this here, you should be placing your focus at the mitral valve level. This allows for greater resolution of the entire LV and helps to reduce the swirling artifacts seen in the apex. So here you can see this is an image where you can see that entire LV and your focus is at the mitral valve level, which is correct. Very rarely do you move your focus. Sometimes you do, maybe in 5% of your contrast cases, but most of the time it should be set at the mitral valve level. That will make sure that we're ensuring that we see that whole entire LV, including the basal segments and the apex. Your TGCs, time gain compensation. This allows for adjustment of image brightness at a selective depth. This is very important. So especially when you're doing contrast imaging, is to make sure that your TGCs are set at home. So when we do our low MI imaging on our machine, ours is home is in the middle. So if you have one of these off just a little bit, it'll make a huge difference, and it can create artifacts. It can create a lot of issues, especially if you're doing perfusion imaging. It can create like perfusion defects that aren't there. So it is vitally important that you really do utilize your TGCs and make sure that they're set up correctly. If you do move them, if you have to move them to to optimize an image, just make sure you move them very slightly and together. You don't just move one at a time. You'd want to move just the whole thing at just kind of make sure you do it really tightly and together when you're moving your TGCs, is to not to create any big changes in your images. Your overall gain, this is important as well. So the overall gain amplifies intensity of the received echoes and uniformly increases or decreases the amount of echoes displayed. The optimal gain should be set to the lowest intensity while still preserving the image quality. And the overall gain does not affect microbubble destruction. There's a couple examples. Sorry, my images are going kind of wacko. But this one here is, this image here is way overgained. So this one is set, I believe, between the green here, is set at 74%, which is too high. So overall gain on this specific machine and this specific setting for contrast imaging for low MI, we usually want the gain to be below 70. And anything above 70 usually creates this oversaturation of the image. And here it's set to 63, which is a much better uniformly not oversaturated image, as you can see here, of the peristome long image. So just a little bit different setting of your gains can make a huge difference. This is just another example of setting it way too high. This is 80%. This is really extremely high. So once again, we get that really oversaturated image here that you can still see the LV, but it's a lot better if you would get down that gain and just not oversaturate your image. Because once again, the overall gain is not destroying any of those microbubbles. So you can still see, the LV, and it's not destroying any of those bubbles, but it just really saturates the image in general. Frame rate. The frame rate determines the repetition frequency at which pulses are received by microspheres. Sector size and imaging depth affect the frame rate, which we all kind of know that, especially with 2D imaging. You decrease your sector size, you're going to have a higher frame rate, you're going to get better images for the most time. But too high of a frame rate can disrupt microbubbles and the incident faster. So the take-home message with this is that you leave the sector size alone for contrast imaging, especially this low MI technique, because the frequency can really affect that. So it's kind of the opposite of your regular thinking, but just kind of leave that sector size alone. Once you start, that's where it stays, and you don't really want to adjust that as you go along. One last thing is the flash impulse. We can take it one step further, and this would be for perfusion imaging. Most of the machines now are set up for that. So with this perfusion imaging, this low MI imaging, you can appreciate both regional wall motion and blood flow to the heart. So the flash impulse is used to destroy contrast in the myocardium. You can adjust the iframes and the eye power to control the duration and magnitude of the impulse. If the myocardium is not dark enough after your impulse, you should adjust your overall gain maybe too high, like we talked about. You may need to increase the number of frames, and having patient take a deep breath in and holding it can also help with contrast images. Perfusion imaging, real-time myocardial perfusion imaging uses continuous low MI imaging. The myocardial blood flow can be analyzed by examining the replenishment of the myocardial contrast following a high MI flash impulse. It's dependent on the microbubbles resonating without disruption. Imaging with low MI provides for good signal enhancement with little bubble destruction. Normal resting myocardial contrast replenishment should be within 5 seconds. This would be for resting echoes. And then normal stress should be within 2 seconds. And this is just an example up here of a nice low MI imaging with that flash impulse. So as you can see, pre-flash, you have a nice concentration of those bubbles in the myocardium. Then you apply that high mechanical flash and you destroy those bubbles, and you see how nicely they replenish. And you want to destroy the bubbles in the myocardium, but not necessarily the bubbles in the LV cavity. This is an example of one of the machines. This is kind of a flash power, and then where you go to get that flash. Every machine, I don't know, I think most machines have this now. I can't say every machine, but if they do, then there should be a place on your machine that you can control your flash power and your flash duration, which would be your flash frames. Here's just a quick example of making sure that I'm not going to play. Sorry. We just want to make sure your flash frames are set correctly. So in this first image here, I'm not sure why that doesn't play. Sorry about that. It just gives you an example of this one is set too low. So once you do that, once you flash, there isn't enough flash to destroy those microbubbles in the myocardium. And this one here is set too high. So the flash is 24, which is extremely high. And here you can see we just destroy way too many bubbles, and some bubbles in the LV cavity as well. So here we have that happy medium where we have 5 flash frames, and then you can see how nicely you're just destroying those bubbles in the myocardium, but not within the LV cavity, which is the optimal thing we're looking for with this technique of using the flash impulse. Last but not least, we can use the eye scan for auto optimization for tissue equalization. And this analyzes the tissue in the image and provides the most optimized image. And you want to use this after all of the other presets are optimized. A couple more things here. This is just an example of, I want to kind of have you think about, oops, sorry. Sometimes we have to determine if it's a machine optimization image, is it a patient imaging, something that's causing the image not to look quite right, or is it administration of the contrast administration? That's what Jess is going to talk about. But this example here, I just want to show you that sometimes you may think it could be the machine setting, but it's actually, you just need to increase your contrast administration. I'm really apologize, my images are not playing like they should. But so like here, you can see this is the optimal 4-chamber view here with the optimal amount of concentration of the ultrasound enhancement agent. So it wasn't necessarily the machine settings, it was the optimization of the administration of the contrast. So just so you know, this is like it's really a dynamic process, and it could be one, it could be other, but you really have to know, kind of what that looks like and what you should change when you're scanning to make it better. So in this case, it was changing the administration of the contrast, not so much the settings in the machine, because everything, you had a nice window, you had all your settings set up correctly. It was more just the administration of the contrast agent. Which kind of leads me into my conclusion on this part. So a couple of things to bring it all together. So the scanning and the machine optimization is the start of diagnostic imaging with contrast agents. The next step we're going to talk about is the administration techniques and the troubleshooting of those images. And at the end, after Jess gives her presentation, we're going to bring it all together again, and we're going to talk about a few cases and additional tips to successful scanning with ultrasound enhancement agents.
It's a privilege to introduce our second BS, RDCS, ACS, FASE, Technical Director and Clinical Manager, Echocardiography Lab, Division of Cardiology, Beth Israel Deaconess Medical Center, Boston, Massachusetts. Welcome, Jess.
Thanks, Matt. Appreciate that. All right. Well, thanks all for joining us today. I'm going to just expand on a few things that Joan talked about before we go into a few case studies, and to bring everything all together here. Here are my disclosures. And I want to talk briefly about the indications for use in our contrast. And it's so important because I think those of us that have done echo for a long time, 10, 15 years ago, it was always taught that we should be using contrast when 2 or more segments of our LV are not well visualized. And that was kind of ingrained in us: 2 or more segments not visualized, use contrast. But that's really kind of an antiquated way of thinking about the use of contrast now. There are so many other pathologies and other things that can really be beneficial for the use of contrast. So on the right is just our policy that we use at BI for that sonographers are supposed to, when they're supposed to use contrast. It's not the only times, but it just sets a precedent and an expectation for when we should be using it. On the left, I love this chart. This comes from the Auto textbook, and it just kind of shows that when we have poor quality images, we know that for a wide range of indications, there is a very high benefit of use for contrast. But even when we have a good quality study, there are still indications that we have a really high benefit of use. Our patients with chest pain, our patients with ischemia, thrombus, and our stress echoes, and our patients where we really need to use to give a really good definitive LVEF. Our patients that are getting considered for ICDs, patients that are getting cardiotoxic chemotherapy, things like that. So even if it's good quality, those are still situations where we really should be using contrast. So that out of the way. So image optimization in contrast, we went through some of the ultrasound system settings we can do. I'm going to talk a little bit about dosing and administration, and then Joan went through it already, but some of the breathing, positioning, and off-axis imaging, and I'm just going to reinforce a couple of things that she stated about those. Really, anytime we're doing a contrast study, we want to ask why. Why are we doing this? What are we trying to show? Because ultimately, the way we inject, how we inject, the settings that we do are really going to be impacted based on what we need to see or what we're looking for. So our goal in our contrast imaging is to have a really nice, clear endocardial border, have a nice homogeneous fill of the LV, really have that apex fill nicely so you're not getting a lot of that swirling, limit your artifacts, and have just a really nice consistent resonance from the base all the way to the apex with your contrast. And again, accomplishing this really differs patient by patient, pathology, heart rate, all these things impact the way the heart uptakes that contrast and ultimately how it looks for you. So we can give contrast all day long, but if we're giving the contrast and not optimizing it, we may not, be showing everything that we should be. The most common artifact that I see is probably swirling. And so when there's swirling in the LV, it's usually because the problem is that there's inadequate opacification, right? So you're not getting clear endocardial borders because you have all that contrast swirling around. And there's a few causes. The MI is too high, so you're destroying your bubbles. You have a heart that just has really bad LV function or like a big apical aneurysm. So you can you'll see all that slow moving blood and all that stasis of blood. So it's really hard for that contrast to be uptake. And then also our injection techniques. Are we injecting fast enough? Are you injecting enough contrast? So this is just an example of what our swirling looks like here. You can see in the apex that the contrast is just kind of swirling around there. So the first way we can fix it is by adjusting our MI, like Joan talked about. And in this image here, we can see that on the left, the MI is far too high. So we're destroying those bubbles and we're not getting a nice fill all the way in the apex. The problem is when you get all that swirling and things like that, you can't possibly, if you're getting enough swirling, you can't possibly rule out a thrombus, especially in a patient, with apical aneurysm or akinesis. So you really want to optimize that MI so that you're seeing really clear borders and definition. And the only thing we change across these three pictures here is the MI. So you can see how impactful that is. MI, the power is really the thing that has the most impact on our bubbles. So we really want to make sure that we're using an optimal setting there. The one situation where you may want to increase your power or your MI is when you are doing the parasternal long view, right? So, and that is just for the inferolateral wall. So the inferolateral wall is kind of the farthest away from the transducer. In this image, it's 11 millimeters away, and so we want to increase the MI so those bubbles can really get all the way to that inferolateral wall and oscillate there to really show that wall. So one situation where if you're in your parasternal long view and you really can't make out that inferolateral wall, maybe actually try to increase your MI very slightly. All right, so for these two images, these are different patients. The question is, would we administer contrast in the same manner for these two patients? Would you administer the same amount and at the same rate? The answer is no, because the image on the left, we see there's a dilated ventricle. You have your basal segments that are really contracting well, but then you have that akinesis in the mid to distal segments. So I don't know if there might be an apical thrombus there. I don't know. I can't rule it out on 2D. So that's a really sick heart, and we really need to make sure that when we're injecting enough contrast to really go all the way into that big apex and fill it nicely. The image on the right, at least from what I can see, it looks like there's probably pretty normal function. The LV doesn't look dilated. So if we inject the same amount that we would inject in the patient on the left to get a good optimized image, you're going to get a bunch of attenuation and it's going to be too much. And so depending on what you're seeing, adapting to that with how much you're administering is really important. So say I injected 1 cc of contrast in both these patients. This would be the result. The image on the right actually looks okay. And there is a little bit of attenuation, which we'll talk about in a minute at the basal segment though. But because this is a pretty normal sized ventricle, this filled pretty nicely with just that 1 cc. The image on the left you have all that swirling because of that stasis of blood flow there. And so 1 cc like that is just, it's not enough or in this particular patient. So you may have to push an extra little bolus to really get that to fill to the apex. I also can't rule out a thrombus here. I have no idea if that's a thrombus in the apex or not, because it could just be swirling contrast. I don't know. One thing to try, there's some patients that can be really difficult to get that apex filled. Sometimes I'll push a little extra and then follow it with like a full flush of saline. And that tends to kind of help push everything through a little bit. And then I'll also, it seems silly, but have the patient take a few breaths for a reason that like increases the venous return, and then it kind of fills the ventricle a little bit more. So taking a couple big breaths in tends to like really push that contrast up as well in my experience. So this is another example of a big LV. We need to push more contrast to get, you know, clear segments and a really good fill here. And so this middle image, it's not bad, but we are getting still a bunch of swirling here. And so we want to make sure that we're pushing enough so you're getting that nice endocardium all the way to the apex and not getting the swirling there. This is kind of off topic, but this is that same patient. I just wanted to point out that the sonographer here did a really great job. In the 4-chamber, that LV was so dilated that the width on our machine was actually completely maxed out, and we still couldn't see really the full LV. So they went to their short axis, you know, with that contrast, and really demonstrated the full extent of that thrombus, which we really couldn't appreciate just because of that size of that LV in the apical floor there. So that's, you know, one thing that they did to really kind of showcase that and really show the extent of that thrombus at each level in the short axis as well. Our focus position, as Joan said, really should be left at the annular level when we're doing our contrast. There is an exception, and that is if you have an apical abnormality and you want to if you're getting a lot of swirling and you want to reduce the swirling. Bring your focus position up to the apex, and that will help reduce the swirling in the apex. So important in our patients with apical aneurysms to rule out those thrombus, to really get clear borders in the apex, and this will help pulling that focus position up. This is just a little side-by-side image. On the left, we can see our focus position is at the annular level here. There is some swirling in the apex. And then the sonographer did a great job. They pulled the focus position up, kind of focused in on that apex there to really show that there's no thrombus. And sometimes there's a combination of both that have to be done. It may not be one or the other. Sometimes you have to push more contrast, pull up your focus position. Sometimes it's not just a one-stop shop. So this is a patient that clearly has some sort of apical abnormality on their 2D echo. This is their 3-chamber view. And again, we can appreciate that the apex does look abnormal here. And this was the first contrast that was given. And this was actually read out. This was the best contrast image that I could find in this study. We ended up bringing the patient back, and it's, we're all learning. We're all, this is a great teaching example of just how to really take the time to optimize. So although the sonographer did bring that focus position up to the apex there, they still did not increase the rate of administration, and so they still got a ton of swirling. And because of that, there is no way to say here that there's no thrombus in this LV. We cannot exclude it. And so, if there is a thrombus, that can obviously be detrimental to the patient if we don't identify that.
As Jess is getting her computer back up, Joan, if you look at some of the questions that we have,
Yes.
I wonder if, yeah.
Let's see. Go up here. So one of them said, sometimes when using the contrast setting, it's very dark until tweaking it. I guess, yeah, I guess sometimes when using the contrast setting, it's very dark until tweaking it. Yeah, it can be dark. And sometimes when you tweak it, I guess I'm not 100% sure of the question, but I'm just trying to understand. Yeah, so I would say once you hit your, like on our machines, once we get everything set up when we're administering the contrast, and then we do like at the very end, we eye scan it too, so it kind of optimizes the image overall, and then it's not as dark. So that may be one thing to help. I don't know if that answers your question or not on that one. And then the MI, I'm not sure which slide that was. There was a question on one of the slides in the previous slide. I'm not sure which slide that was pertaining to. It was where was the MI? If you can just elaborate on that, I could probably answer it further. And then the other question is, will this video be available to review after the session? I believe yes. I believe this will be up on the ICAS website as well. So
we were on the slide with all the swirling, and we were talking about how, you know, sometimes just bringing that focus position up is not quite enough, and you do need to increase that rate of administration as well. And so when we did that, we brought the patient back, and this one was difficult, really to optimize. It was just one of those that apex did not want to fill. But you can see what a difference it is when you really take the time to push more of that contrast, push at a higher rate. We followed it with saline to fill that apex, because now we have, not only can we clearly state now, yes, we have this slightly aneurysmal apex. It's actually dyskinetic in, you know, certain areas, but now we've definitively ruled out that there's no thrombus. So you know, we really need to make sure that we're taking the time to optimize when we're using our contrast. All right, so attenuation is kind of the opposite, right? So the attenuation is when you push too much contrast too fast, and what happens is those basal segments kind of get like shadowing from that attenuation, and it's not always bad, because, and the patient on the left, you know, I will say that apex is so nicely shown here because they did push a little bit more. But in a patient like the one on the right, where you're really just trying to show wall motion, you need to, you know, make sure that you're you know, injecting at the appropriate rate, and not too much. And so how to fix it? Well, you can just give it time, right? Give it some time to cycle through. You could also increase your MI for, you know, for a second to burst some bubbles, but it will cycle through, and then it'll go back to a regular, a more uniform way. And I'm not going to go too much into this because Joan did talk about this, but yes, breathing I think is underutilized and really important. And so this image here, these are just the only thing we changed in these side-by-side images was that we had the patient take a breath in. And so you can clearly see that the patient on the right, we're getting such more information than the one on the left. So definitely use that breathing to try to optimize. Other like funky things that happen, I've had sonographers call me and they're like, Jess, can you come to the floor? Like, I'm pushing contrast and I'm literally not seeing anything on my screen, or I'm only seeing like a few bubbles. It's really weird. You know, remember, we're using bubbles and they burst. And so if you go to inject and you're getting resistance in your IV, you're probably going to be bursting bubbles as you're pushing. So really flush the IV first with saline, just to make sure it's a good line, because the second you hook up the contrast and start pushing and you're getting resistance, you're destroying bubbles. So just check the IV, no resistance. If the patient has an IV filter in, it's not going to work. So that IV filter has to, we get a lot of people that have the IV filters in, and so that's going to instantly destroy the bubbles. And also make sure you're mixing per the manufacturer's instructions, because you want to make sure that for us, we use one product and we dilute it, and so if you don't dilute it out the right way, it could impact the administration. So just kind of some funky things that happen there. I'm going to reinforce the foreshortening and going off axis that Joan talked about. It's so important. And it's the foreshortening particularly, and if you have an apex that you see down, kind of going through and sweeping through, it really does make a difference. When we know that when we're foreshortening our images, we are not seeing the true apex, and we could be missing things, as Joan beautifully demonstrated in her earlier slides. So this study is a 78-year-old male. He had CAD, shortness of breath, AVR. And so we can see his peristernal long view here, and then his apical views. We can see that this LV is foreshortened, right? I can see that the apex looks rounded off, and really it shouldn't be rounded like that. The other thing you can do, if you do biplane on all of your patients, when at least we use GE, so at least with GE, when you first trace, you have to do like a second click to connect the base to the apex. That measurement is typically between 7 and 9. And if it's not, you could be foreshortened. So that could be one way to look at, to troubleshoot, like, am I foreshortened? But really, you should just be able to look at this and be like, yeah, that's a bit foreshortened. And then here's the 2-chamber as well. So the sonographer used contrast, and we can see the walls here, but I can still see that we're foreshortened. You can see that ventricle is rounded in the 4-chamber, and then how kind of little that ventricle looks in the 2-chamber as well. And so what the sonographer did, which was great, because for us, what I tell the sonographer is if you are getting an image and it's a great image, but it's foreshortened, and then you go down the rib space and it's really not great and you really can't see anything, go and use your foreshortened image for like your Dopplers and things like that, because you have that really high quality image, and you could probably assess color Doppler on the valves better, and then go down the rib space and take your images with contrast in that lower rib space, because when you do, that's when you can identify abnormalities. So here we can see that there is a small aneurysm in the apex that would have been completely missed had that sonographer not gone down that rib space. And then this is it in the I don't know, or 2-chamber, I'm not sure, but just another view of it here as well. And then just a side by side, just to demonstrate how different that ventricle looks side by side when we're foreshortened versus not foreshortened. So you can see how much more elongated that ventricle is when we're on the true axis. This patient, she's a 57-year-old female. She's presenting with dyspnea and pleuritic chest pain. Same thing here. We have a tough patient, a tough study, but I can see that the apex looks a little rounded. I think, I'm actually not 100% sure because I can't really see the apex very well. And then when we use contrast, we can clearly see that the apex is akinetic, and which is great. Well, not great, but it's great that we could identify that. But the sonographer went one step farther and really did a good sweep through that apex to try to look for any sort of thrombus because of that akinetic area. And then when she did, she found that small apical thrombus there. And you can see how this picture, the ventricle is a little bit more elongated. You can kind of see that it's a little bit of a different shape. It's not so rounded off. So that's really that true apex. And so she did a great job kind of going through and identifying that and kind of going down that extra little space there. And this matters, right? And I can't stress this enough, like, the why in contrast is so important. So, well, why do you bother using it? Well, this patient, we completely changed management for this patient, right? She was at a high risk for an embolic event or a stroke. She probably would have needed further diagnostic studies like a CMR, but instead, because of that, we identified that she went on heparin for anticoagulation and then long-term anticoagulation with warfarin. So it matters, and it does make a difference to these patients. I think that's kind of what I have for on like optimization and things like that. So I'm going to jump into a few case studies here. And Joan, if I'm taking too long with case studies, feel free to just jump in and,
You're fine. You can do, yeah, I have a few, but you can go ahead.
Okay. All right. So at the very basics here, we know that I always like to show the wow cases, but I think it's always good to kind of reinforce the basics of kind of the day-to-day patients that we're using contrast for. So Here's a patient that came in, and on paper, they seemed like a pretty good patient to scan. I think they were 5'8", like 140 pounds or something like that. And then, you know, they get there and this is, you know, what you see. And I'm sure this is all too familiar to the sonographers on the meeting today. And so we have that, and without contrast, well, what's the EF, what's the wall motion abnormalities? I have no idea. There's no way that I can give a comprehensive answer to any of that. And so by using our contrast, we can clearly see side by side here how much better we're able to see wall motion abnormalities. We can see that septum's a little down, the apex looks down. And then in the 3-chamber as well, I think it's really a nice, again, septum looks down, and then that inferolateral wall does look okay. So this, you know, completely changes for our patient the report and management just by using that contrast. And this is just another little side by side of some wall motion abnormalities here. You can see, I think there's something funky in the apex there, and really nicely demonstrated here with the contrast. I talked before about kind of those indications where we use contrast in the good quality study, how it can be beneficial to use. This woman came in last Christmas. She was complaining of shortness of breath, chest pain. She had some stents put in some time ago, but she presented to the ED, and she was hypertensive. She had elevated troponin. She had some inferior ischemia, and the team was trying to decide. You know, it was difficult to say, is this type 1 or type 2 and STEMI? Is this a legitimate, you know, CAD causing this, or is this like a demand ischemia or something like that? And so they said, well, we can either do a stress test or send her right to cath. And they were going to keep her do a stress test the next day, but instead we did an echo while we were there. And I'd say we can all agree this is a pretty good quality picture, right? We can see the walls pretty well. I think we can see the walls pretty well here. We can see the EF looks normal. And so, and then the 2-chamber here. So the question I have is, are there wall motion abnormalities here, and would you use contrast? And I think, you know, this is one of those cases where I was really concerned about, there was one wall where I felt like it might have been not actually thickening. And so I chose to use contrast. And if you look here, this is our 4-chamber. So we have our basal to mid anterolateral wall here, and it almost like hinges off here. And so there is a little bit of hypokinesis in this basal to mid wall here. And then in our 3-chamber as well, everything kind of looks like it's thickening well up here towards our apex, but this basal to mid section does look a little bit sluggish comparatively. And so the findings on the report were that, you know, new wall motion abnormalities. The team was concerned about worsening CAD. And they did go in and do a cath, and they found significant, severe, 3-vessel CAD. So, you know, they would have cathed there anyway, but the point here is that, you know, we saved her a stress test and we got to that answer faster. So instead of doing the stress test, they skipped that. They obviously went right to cath and found this. This is similar. This patient presented, they had a cabbage ×2, and they had new Q waves on EKG. So the concern is there something wrong with the bypass? We need to look at wall motion abnormalities. And this is actually a little dark. So sorry about that. This is a little dark, but in general, it's a good image. I think the image quality is pretty good here. Here's our 4-chamber, and then our 2-chamber, 3-chamber. And if I had cranked the gains, I think we'd all agree, like, you could see the endocardium pretty well, but just in case, we used contrast. And then you can actually see a very small area of apical akinesis here that was not appreciated on the 2D images. So there, and then right here as well, you can see it very nicely. So these were new wall motion abnormalities, and she did have to go back to the cath lab. And I need to look up the rest of the follow-up on her, but she did have, there was an issue, and I have to look that up. But just an example of a way this would have been completely missed without without that contrast, and then the 2-chamber as well. Switching gears a little bit from wall motion abnormalities and such, we always neglect, well, not always, we sometimes neglect the RV. I think we can all agree we're always very focused on the LV, especially when it comes to contrast administration. In fact, I don't think I mentioned the RV once today so far. But, you know, so this is a guy that's presenting with, he has bilateral DVTs, and he's coming in, image quality is really tough. And I just, Joan, why don't you jump in with a case while I
just had a couple tips as far as flashing and when not to flash. Then a couple of these first, and then I'll go jump into the cases that I have, a couple of those. This is just an example, like we talked about that perfusion imaging and that low MI imaging. As far as when to flash and not to flash, this is just a couple examples of this image here. Pre-flash, you probably would not want to flash on this image because the image is really dark. You don't have enough contrast in the myocardium or in the LV to flash on this patient, if that makes sense. This patient is a little bit brighter, so on this patient, I would probably go ahead and apply that flash because you got enough contrast in the myocardium and in the LV here. These are just still images, so this is another example of, like, here the myocardium is really dark pre-flash, and then we went ahead and flashed. So in this case, there's no reason to flash because it's already dark and you can't really appreciate the replenishment if it's dark pre-flash. So then you just, you know, you create more havoc and you create more destruction of the microbubbles in the myocardium and in the LV, and you really can't appreciate the perfusion. This patient, a little bit different here. These are still images, but this, you can see we have enough contrast in the myocardium and in the LV. We go ahead and flash, and we're destroying those bubbles in the myocardium and not so much in that LV. And then you can really appreciate how it replenishes throughout the myocardium post-flash as well. So this one, to flash or not to flash, I would say yes. So in the beginning, we have that nice, you know, opacification of the myocardium and the LV, and then we flash, and we have that nice dark post-flash where we're just destroying those bubbles in the myocardium and not really in the LV. My first case study is just a case study of a very low MI imaging technique to kind of highlight why we do this. So the advantage of this is that these techniques, compared to B mode, low MI harmonic imaging, is that it produces better tissue cancellation and greater signal to noise ratio sensitivity for detecting the agent, and less microbubble destruction due to the low MI that is required. The clinical effect of this provides high spatial and good temporal resolution that permits this simultaneous assessment of the myocardial perfusion and the wall motion, like we mentioned earlier. This technique detects the nonlinear activity at the fundamental frequency, power modulation, and interpulse phase and amplitude modulation pulse sequence schemes. Less attenuation and better microbubble contrast signal. So you really get that improved apical and basal segment visualization and overall LV opacification. Apical abnormalities, hypertrophic cardiomyopathy. This variant is present in about 7% of patients with hypertrophic cardiomyopathy. This variant may be missed by TTE due to the incomplete visualization of the apex. So if apical hypertrophic cardiomyopathy is present, spade-like appearance of the LV cavity in diastole with marked apical myocardial wall thickening will be clearly evident on the enhanced imaging. Here are some 2D images of a patient. 4-chamber here, 2-chamber, and 3-chamber. Pretty nice images, pretty nice quality images, but we're not quite sure what's going on at apex. And this patient, we went ahead and used that contrast. I'm gonna freeze. Okay, so in this case, do we want to use the low MI imaging, or do we want to use the very low MI imaging? So in this case, we want to use the very low MI imaging. It is recommended that UEAs be routinely used with very low MI imaging in evaluating patients with hypertrophic cardiomyopathy. So here we go. This is the 4-chamber view of this patient. Injecting that contrast, and this injection we're doing like this. We do like a continuous infusion, a diluted infusion, so we get that nice continuous infusion of the contrast. And then this is the end result here. Once it's all into the uptake is taken into the LV. With the correct window, the correct amount of contrast administered, and the settings in your machine, you can be able to appreciate the apex here. And this was missed on previous echoes on this patient.
Yeah, Jen, we've seen such an uptick of our apical HCM patients lately. I wonder, we see so many now, and I just wonder if we're just identifying more of them now because of there's so
Could
much
be.
more contrast use. Yeah.
That could be very well a true statement because we've caught this. I think this patient was in our lab previous numerous times. I think we missed it. So that's why it's just so very important to make sure that you get that correct window when you're scanning, especially to rule out these hypertrophic cardiomyopathies in these patients. So here's
Yeah.
the 2-chamber. Again, you can kind of see the apex here and here in the 3-chamber.
And then for everyone, the one thing we really want to look for and why it's so important in these cases to get the true apex is that there's a high incidence of apical aneurysms with these patients.
Yes.
And
Yes.
those are the ones that are at much higher risk clinically. So these are patients that are getting ICDs and getting on thromboembolic therapy. So it's really important for us to use contrast in these patients for that reason, so we can identify if there is those apical aneurysms.
Very good point. And just like to making sure that you have that steady image and like just getting those good quality, like 2-3 beats of an image so they can really appreciate the aneurysm. Sometimes it goes in and out of the plane as well. So then I think the next slide I have is like maybe some of the previous scanning of the patient, I think. Yeah. So these are just some things that might help you. Like, so here I think, the plane's not quite there. The breathing's not quite there. That contrast administration, I think could have been a little bit more on this image here. We probably would have been able to bring it out a little bit better. And this one, I think maybe just a breath in imaging plane might have helped because here they can't quite see, once again, that apex. And I think with that breathing technique, you can just bring it in a little bit better. I'll do one more case here, and then Jess, if you have any more, you can go ahead too. This is uncommon. This is a non-compaction cardiomyopathy case. So increasingly recognized abnormality that can lead to heart failure, arrhythmias, cardioembolic events, and death. So due to alterations of the myocardial structure with thickened hypokinetic segments that consist of two layers, a thin compacted subepicardial myocardium and a thicker non-compacted subendocardial myocardium. Here are some images with 2D. This is a 4-chamber, 2-chamber, and 3-chamber. And here you can, I think, appreciate in the 4-chamber here, to see something going on. You might see some of that non-compaction. You're not quite sure what to do. So I would definitely use contrast. But the question is, do we use the conventional LVO or do we use the very low MI imaging? In this case, we want to refer to the guidelines. So the contrast-enhanced studies may be helpful in identifying the characteristic deep intratrabecular recesses by showing microbubble-filled intracavity blood between the prominent LV trabeculations and the LV non-compaction is suspected. Recommendation for this one is to use an MI that is somewhat higher than the very low MI imaging. So this is one of those cases where you want to use your MI to 0.3 or 0.4. So this will better distinguish the myocardium trabeculations in the non-compacted myocardium from UEA presence within the deep recesses. The higher MI at real-time frame rates destroys the low velocity microbubbles within the trabecular myocardium before they can replenish, while the higher velocity intratrabecular microbubbles in the LV cavity can replenish, permitting better delineation of the non-compacted layer. So here we're using that setting where we're sending at different frequencies. So we're using that conventional LVO setting. Your MI is a little bit higher in these. I don't have it on here, but usually it's probably in the 0.3 area or above. So here you can really appreciate with more destruction of the microbubbles, you can really appreciate that there is those recesses, and this is really a good case of non-compaction. And we also did this patient with real-time low MI imaging where we're sending and receiving at the same frequency, and you really can't appreciate it as much as you can with the other images. So it kind of gives you an appreciation of why you should be using one versus the other. So here it doesn't really show it quite as well as the other images do. And I think I have a side-by-side of that too here. So here you can see kind of the difference of those two. So this is one case that you would definitely want to use that higher MI and that conventional harmonic, LVO setting that you have that most machines should have as well. I'm just gonna see what time it is. It's 1:13. Jess, I have one more case, I think, unless you have one that you want to do, or
You can go ahead. I have some, but that's fine. Go ahead.
I might just do one more quick one, and I'll send it back to you.
Yeah.
So this patient came in with chest pain, had a focal aneurysm deformation of the basal to mid inferior wall with preserved contractility. These are the 2-chamber views. this is a separate one. I'm sorry, I was thinking I had a different one. Anyways, okay, so this, I'll just talk about this. So this is like, this is a good example of making sure that you can kind of appreciate the lateral wall, because sometimes I think that's the biggest thing we suffer from, is really appreciating the lateral wall in some of these cases. So this is a case of a patient that came in, it was an ICU patient. This is your conventional LVO setting, you know, sending and receiving at the same, your MI is a little bit higher. And this is your low MI imaging, sending and receiving the same frequency. Your MI is probably below 2. You get such a much better delineation of the LV. And here we can really appreciate that really focal wall motion abnormality here in the lateral wall. Okay, this is the one I was talking about. Okay, so this is a 56-year-old male that came to the ER with chest pain. The urgent cath was performed upon arrival. He had 100% occlusion of the mid OAD, 50% circumflex lesion proximal, and 50% lesion in the distal vessel. He had 2 stents. An echo was ordered for myocardial infarction. Patient still complaining of chest pain after the cath. The STs still elevated. Recheck EKG and get an echocardiogram. Chest pain onset to dilation time appeared to be about 3 hours. May have no reflow. I have showed this case several times in different presentations, but this is one of my favorite cases in this patient. This is the 2D, and this is the technique that we use with the low MI imaging. And here you can definitely appreciate that this person has this deficit here in the LV, in the apex. There's no reflow. There's, you know, this has a perfusion defect here because the blood flow is just not getting there with the uptake of the contrast. This was very, very beneficial information for the physicians. Same patient here, we just turned this into a different setting, the LVO setting, this specific machine. And you can kind of tell the difference. I don't know why I guess this is not I don't know what happened. I thought this was LVO setting. This looks like it's the same setting, but for some reason, anyways, I was trying to bring the point forward that doing this low MI technique, sending and receiving at the same frequency, for some reason that is the same, but I was thinking it was different. But anyways, but it really, you can really appreciate the difference of the settings on this machine, and that now we can really see that no reflow here in the apex of the heart. So the echo findings demonstrate dramatic reduction in the capillary blood flow despite TIMI3 flow in the epicardial vessel. 6 months later, patient had another echo, distal apical septal akinesis and moderate anteroseptal hypokinesis. So those are mine. If you have any left, I can give it back to you, Jess, if you have one more.
Yeah, we have just a couple minutes left. I'll try to finish up that one that I had on. If my computer decides to work, I'm not sure.
I just want to give a huge shout out to the people in our lab, our physicians, sonographers, nurses, all sorts of support staff. They're all wonderful. Dr. Thomas Porter for all his passion for contrast imaging, and my little granddaughter, Jade.
Oh, so cute.
Okay, I will send it back to you here.
So his parasternal long view here, and then when we go to, this is the only view we could get for our, this is like a pseudo apical, subcostal, something or other, and it's all we could get. You know, I can appreciate here that the RV doesn't look good. It looks dilated. I can't really see any sort of wall motion though, and can't really evaluate function. What I didn't expect to see was the highly mobile thrombus that was hanging around in there, which kind of changed the course of this patient's treatment. But now that you look at it side by side, you can kind of see on the left that, oh yeah, maybe there was something there, but definitely would have never, definitively commented on that without that contrast use there in the RV. So I know we talk a lot about LV thrombus and the importance of contrast for our LV and things like that, but there is, definitely utility for our right side, as well. I'm not going to really go through this one because Joan just did her apical HCM, and this is also an apical HCM. But this is just nice because it has that little apical aneurysm that we talked about here, and so we can see that outpouching in the apex there, and we really want to in these patients really bring up that focus position and really focus on that apex, especially in these patients because it's so hard to identify these small aneurysms sometimes, and we really want to make sure that there's no thrombus. So really important to optimize in this patient subset. So increase your injection bring your focus position up so you can really rule out any sort of thrombus in that apex there. And then this is just another little side-by-side patient with the CM with a little outpouching on the top starting. I will end with this case because it's a good one. This patient came in with no prior cardiac history, no prior medical history, healthy as a horse. They transferred him in for a inferior STEMI, and this is what we got in our parasternal long view. And you can see this at first glance. We may think that this is pleural effusion, pericardial effusion. But if you look really closely, there is a wall rupture here in the basal inferior lateral wall. So how did we confirm that? Well, we used contrast. And so that's our inferolateral wall here. And obviously there shouldn't be contrast all on the outside of the heart there. And so really nice demonstration of that. And, you know, we used contrast. We had to follow up with this guy many times because he kept, they patched it. And then he kept rupturing the patch. And so we had to follow up with him so many times. And all of his follow-up studies we were using contrast on, particularly he presented later with shortness of breath. This study, you can actually clearly see that there is communication here when he ruptured his patch the first time. And then this is like a subcostal view, and we had used some bubbles so you can see the communication there. But when it really came into good use, this is another follow-up echo he had. Here's his parasternal long view. This is like a kind of a 3-chamber view. And we're seeing some like movement here, and then we're seeing a more dark space outside of the ventricle here. So our thoughts immediately are he ruptured again, that, you know, we have to, you know, but we use contrast and there was nothing going outside the LV. So the patch was intact in this instance. And then if you look side by side between his initial presentation on the left here with all that contrast on the outside, and then his post-surgery number 3, I think, where he got that. And we can clearly tell now that there's no contrast on the outside there. So I will end there with that case. Thank you so much. And I apologize again for my technical issues here. The question is, are there any tips or tricks for UEA usage at peak stage of an exercise stress echo? I think the best tip and trick is to use infusion. If you have infusion or infusion pump, you get pretty consistent administration of ultrasound enhancing agents throughout the entire time. However, I realize that most of us don't have that, including myself. And so it is a tough thing to do. I push a lot when I'm at peak. I push like a few cc's because by the time the patient gets back to the treadmill, all that attenuation that may be there from that initial push is going to be gone. So we inject like 15 seconds before the patient gets off the treadmill. I throw in like 3 cc's, and then by the time they get back to the bed, there's plenty of contrast left over to get my imaging. I don't know, Joan, if you have any.
Yeah, we kind of do the same thing. So we do that low MI imaging, and then we have our nurses that inject for a stress echo. So it's kind of nice that when we do inject the same thing, we inject before the patient gets off the treadmill. We inject a good 1 cc because we do like a diluted solution with the contrast that we use. So we give like a diluted like a 1 minute before they got the treadmill, and then right away then the nurse starts injecting again like every 15 seconds. We give another injection. And you know, it's very dynamic. So when you're scanning the sonographer, you know, if we need more contrast, we'll always say, can you increase it or can you decrease it? Because sometimes with the cardiac output, it increases post-stress. You know, when they're off the treadmill, you get a lot of contrast all of a sudden. So sometimes just slow it down a little bit. You know, and sometimes what we can do too is that because we do the flashing, we do the perfusion imaging. So sometimes flashing will get rid of some of that contrast if you have too much. Just do a couple flashes to kind of tone down that, you know, if you have too much contrast in the LV. But we kind of do that same thing. Yeah. But I think the key to that is making sure that we inject before you get off the treadmill is really helpful. And then making sure that you kind of have that consistent injection post. Like you said, a pump is probably the best thing for that consistency.
Yeah.
So, but not everybody has that in. Yeah, and not everybody has nurses to help either. I mean, we're blessed to have that, so we can, we can do that, but not all places do that. So I guess it's kind of dependent on what you have and what resources you have too.
Yeah, I think if you could see my stress echo room, you would laugh because it's so small, and I literally inject and then I'm like jumping over things to try to get back to my machine on the other end. And one of these days I'm going to break a hip, but
Oh my gosh. So we have people in we have the nurse, we usually have a fellow, we usually have a physician in there. So we have a lot of people in our rooms. So I guess we're blessed in that regard. We have options, but it is nice that we have that other staff member that can help facilitate the contrast, which I think is really important, because sometimes it's, in what we do, because we do the flash and the replenishment, so it takes us a little bit longer kind of to do our stress images, because we have to, we're capturing and then we flash and then we wait, so it's a little bit longer process. But
so one question, how old was that guy? I think they're probably referring to the guy that ruptured his wall. I think he was like 64, 63 or 64. He's young.
It's amazing what we're seeing lately, like I don't know if it's post-COVID, I don't even know what it is, but we're just seeing so many just sick patients and so many crazy things, that.
Yeah, we had a patient, if we had time, I would have shown this one. We had a patient that came in with Loeffler's endocarditis the other day and had the entire 2/3 of their LV filled with thrombus. I've never seen that before.
Wow.
Pretty intense.
Yeah, and that's what I say, like, no heart's the same, not one heart's the same. And it's such a true statement. It's amazing that you never know what you're going to see when you put the probe down. I think that's what makes it so exciting. And, how we can help people, especially with just good 2D imaging and also good contrast imaging.
Definitely.